a lot of international friends right here, national of course, and bon appetit at the same time. Before starting the session, we have only 1 hour, maybe for me 5 minutes more, and we have with me 4 speakers. We are 4 speakers. First, I would like to thank Anika, then Heidi and his group, and the Turkish Soylu Medikal, who are the group. First, I would like to introduce Dr. Hayden. Could you stand up, please, Hayden? Narrating is one of the orthopedic surgeon, high level, not mid-level, high level in my country, maybe in Europe, in the world. And he is the instructor, he's a professor at the Sultan Le Magnificent Suleiman University in Istanbul. And he was in a fast traveling fellowship between 1997 and 2004. And he had a lot of papers published in international journals and a lot of scientific works. He is one of the experts in fundamental surgery. He is the president of Turkish Fundamental Society. Previous or the next vice president, next president, and very welcome. Thank you for your input in advance. Secondly, Professor Spoliti from Roma, stand up please. And he is the knee and shoulder surgeon. He works at the San Camillo Hospital in Roma. He is the director of the day surgery unit at the department. In this department section, he performed knee condyle defect repair, ACL and TCL reconstructive surgery, rotator cuff repair, shoulder instability, etc. In the last 4 years, he started to use regenerative medicine in the treatment of joint traumatic and degenerative cartilage defect. That's me. He have a respect to the biology. Stanislavski from Poland. Konrad is one of the experts in Poland in orthopedic surgery. He is still working at Medical University of Warsaw, and he has a lot of international communication, visiting US, Professor Kaplan, Mats Friedberg, René Verdon, and all friends, all very well-known friends around this planet, not only the Europe. He is the head of private sports medicine center, Lekmet, Warsaw. Is it correct? Lekmet. Okay. The Turkish language and Polish, maybe he used a lot of Turkish words. Effendi, like. In 2001, he had finished PhD thesis, supervised by Professor Kaplan. He investigated the Hyalonect biomaterials as scaffold for MSc breast cartilage repair. And I'm Dr. Goral from Hacettepe University. I try to be a conductor of this high-level scientific session. I like jazz music. I have a respect to the improvisation. You will ask at the end of each presentation, but with the harmony. And now I would like to start with my presentation. Can I start, Hadi? Yes, thank you. Arthroscopic cases using Hyalofast in combination with microfracture. Other techniques, then comparing clinical efficacy of one-step regeneration versus two-step, background and advantages of Hyalofast, including cost effectiveness, comparison between multiple chondral lesion treatment option, and certification. Okay. I use Hyalofast at the talar dome osteochondral lesions too. The talus osteochondral lesions, we can make a definition like that: defects of talar dome cartilage and in the underlying subchondral bone. There are a lot of friends use osteochondritis dissecans. No, osteochondral defect or osteochondral lesion. Trauma can be the cause. The other one, ischemia, necrosis, and the other factor, like genetic, can be the cause. We can see this at the etiology. According to the guideline for treatment of all osteochondral defects, you can see on your left lesion type and some treatment options. But if there is a cyst, if that of the osteochondral lesion is very high, very thick, we have to think 2 times or 3 times, because first we can put auto or allo bone graft, then after I can use Hyalofast or hyaluronic acid. Last year, last 2 years, we made the publication about the talar dome osteochondral defect treated with hyaluronic acid 3 times of injections and half dose, and accepted as an award group in last year of academy meeting in United States. And here you can see 5 stages. Stage 1, stage 2, A, B, and stage 3, 4, and stage 5. Look at the Hyalofast, non-woven pad made of hyaluronic acid, semi-synthetic derivative of hyaluronic acid, naturally occurring extra-articular matrix, molecular and major component of human cartilage, and biocompatible support for mesenchymal cells. I use this with mixing with PRGF. I have 15 patients in the last one between 2012 and 13. Mostly injury mechanism is low impact trauma with supination and external rotation. Here you can see an osteochondral defect right here, medial side, but in GBGS 2009, I think, Aaron and his group said that mostly seen on the lateral side. In my practice, I see mostly in the medial side. All are the place for all my cases are in medial side. You can see I use anteromedial portal, then anteromedial portal upper than the line of the anterior rim of tibia, right here. I use my microfracture from the same area, like that. And you can see after the microfracture, the blood supply can come from the subchondral bone. Mostly I don't use a tunicate in talar dome osteochondral lesion. And now, about 6 months, I started to use nano fracture. And on the other side, I don't forget to regularize anterior lip of the tibia. I make the shaving of the anterior rim of tibia. Okay, and I don't know if it works or not. Fully arthroscopically, I put the scaffold inside of the lesion. After 6 weeks, I can see the prototype of the hyaline cartilage. In other case, like that. For this, I try to shut down the fluid. Then after, I put the scaffold with PRGF inside of the new crater. Then the end of the surgery, arthroscopic surgery, before the end, I make the regularization of the anterior rim for prevention of the impingement. On the other side, this is the cartilage defect after the reduction of the malleolar fracture under arthroscopic control, and right here I put Hyalofast with PRGF after the stopping the drainage fluid of the arthroscope, and at the end, after 1 year, I need to make second arthroscopy. Grading population, as I told you before, debridement, regularization of anterior tibial rim, very important. Prevention of the impingement, then microfracture, nanofracture, this is my favorite, about 6 months. Then putting the scaffold with PRGF and end of the surgery. I use this at the size of the crater is about 2 centimeters square. No discrimination between low and high demand patients, mostly young and middle-aged patients. Contraindication, look at the active infection, inflammatory arthritis and collagen disease, excessive varus and valgus malalignment in the knee joint. Easy to use, they are resorbable, safe, clinically efficacy in chondral osteochondral degeneration. Hyalofast and Fibrox scores higher hospital in my practice, need controlled arthroscopy, need long-term clinical and academic results. For the next step, very important, prospective randomized multicentric control study between 4 or 5 centers of excellence, and I need to start to think the second generation, maybe the third generation, combination with the other parameters like collagen, etc., etc. Thank you. Now, Norita, I would like to invite you to the podium.
Thank you. Thank you for inviting. It's a great privilege for me to be with you today on the ICRS meeting. I will start with one of this year's best studies for me. Earlier this year, our colleagues from Rizzoli Orthopedic Institute showed that starting with the new millennium, there is a growing interest in cartilage regeneration at all levels. In vitro tests, preclinical animal studies, and clinical applications. In the conclusion of the study, the final words were as follows. Different one-step scaffold-based strategies are emerging to simplify the procedure and reduce the costs. The traditional technique of microfracture only is a one-step procedure and it reduces the costs. However, there has always been concerns about the efficacy of microfracture. Later this year, in the same journal, this month, in the latest issue of Arthroscopy, we obtained some answers to these concerns. In this high-level study, which is a systematic review of level 1 and level 2 studies on microfracture applications, Goyle and friends stated that beyond 5 years, treatment failure after microfracture can be expected regardless of the size of the lesion. Almost all microfracture studies in the cartilage literature agree on good clinical outcomes at short term, but doesn't say much about the failures later. And to understand what it means in this common sentence, I looked up the dictionary. In the dictionary, I see that there is a part saying what scientists say in research papers versus what they actually mean. This is one of my favorites. The results will be in a subsequent report actually means that I might get around it sometime, and if it's published or if it's funded. Or if the scientist is a surgeon, in my experience, may mean once, in case after case, may mean twice for a surgeon like us. So, if we say microfracture with good short-term results, this may actually mean that not that good mid and long-term results. Let's take a look at our colleagues who are involved in heavy metals in the joints and what they do when a failure is experienced. You can remember this urgent recall notice 4 or 5 years ago. The recall came after a data from a study indicating that the 5-year failure rate of this product is 13%. Although the failure was just 13%, there was a recall, and no need to mention about the lawsuits and also the compensations. For microfracture, we got used to seeing these kind of success rates for many years. With a failure rate of almost 30%, even in the short-term follow-ups, and also deterioration of the ICRS scores in studies one after another, and also arthroscopic findings and histological findings, we can conclude that microfracture is a matter of concern about the problems. Later this year, in a current concepts review from one of our well-known, respected journals, the İCRS, the comment was on hyaluronic acid. To our knowledge, hyaluronic acid is the only biological adjunct for the treatment of osteochondral lesions. Thanks to Professor Doral and his great work. 2 or 3 years ago, Professor Giannini from Rizzoli Institute, this is a picture from 10 years ago, he didn't change any, but that's me on the right, 10 years ago. And he said that evolution in the surgical technique, new biomaterials, and more recently the use of BMDCs permitted a marked reduction in procedural morbidity and costs of the one-step technique able to overcome all the drawbacks of previous repair techniques. In this study, he compared 3 main groups of patients. One of the groups was open ACI group. The other one is a big group of arthroscopic ACI cases, as you see here, 46 cases. He used the HIF11 matrix in these cases. And the other group was a bone marrow concentrate and platelet gel, again used with the HIF11 matrix scaffold. And when we look at the results, we see that there is a similar pattern in all three groups. Open ACI, arthroscopic ACI, and BMDC have the same kind of improvements in Hyalofast scores. So, if these three groups are equivalent clinically, then we need to check them financially. The open ACI group costs about more than 14,000 euros. But if you perform an arthroscopic ACI, you have a 32% of reduction in the costs, with it being still moreover 9,000 euros. And if you perform a BMDC transplantation using a Hyalofast scaffold, the cost is around 4,000 euros, which means another 55% of reduction in the cost. However, if you only perform a microfracture plus a Hyalofast, then you have another 78% of reduction in the cost. And the Hyalofast cost is just 6% of an ACI procedure. So I believe that in the cases of clinically equivalent results, we should proceed with the financially superior ones, and that's what my facility does in most of the cases. I don't want to go very deep on details for hyaluronic acid, but we know that it's the principal component of the extracellular matrix, and it's biocompatible, so it's a very safe production. And also, it has long-term chondroprotection and chondrogenesis effects. The studies starting in 1980s. Hyaluronic acid also reported to bind more cells, enhance bone formation, act as an anti-inflammatory agent, and in some dental studies act as infection study. So, for hyaluronic acid, I believe that there is a two-pronged informative role. One of them is the biological role, and in the case of IF11, which is a matrix, we have also a structural role. Two-pronged roles may be sometimes disastrous, as seen as here, but Hyalofast is not one of them. I believe that it's a two-pronged product with a better outcome. So why 3D why do we need a 3D scaffold matrix to obtain good results? Inside the body, cells reside, proliferate and differentiate with a three-dimensional environment. So isolated chondrocytes will lose their differentiated phenotype in two-dimensional cultures. And then the differentiation process may involve a shift towards a fibroblast-like phenotype. And to overcome this problem, we must relocate them in a 3D environment. So the differentiated chondrocytes can recover their phenotypes. And this confirms that a 3D environment is a pivotal factor that has a significant role in supporting or in restoring the chondrocytic phenotype. I will end my presentation with just a few cases. This is one of the classic defects that we commonly see in these kind of cases. And while we are performing this technique, I want you to compare it with an open ACI with the first generation using periosteal flaps. It's very easy to use, it's very easy to handle it during the operations. And Professor Doral showed some arthroscopic cases for ankle. So I want to show you some open cases with malleolar osteotomy. You can treat these kind of big defects with microfracture and then covering the defect with Hyalofast applications. I sometimes shape the Hyalofast to the shape of the defect, but I still use this remaining part as a second layer because it can be used on both sides. Just a small video. This was just 3 days ago. One of my colleagues, during his arthroscopic surgery for an ACL reconstruction, sees a medial femoral condyle defect and performs microfracture on it. But as he didn't have any Hyalofast with him in the operating theater, then after 3 days he sent me this case for arthroscopy. And as you see here, after 3 days, we see a lot of synovitis in the joint. We have to resect this synovitis. Then after that, we have to make a recleaning to the defect with a re-microfracture. And then after we obtain the suitable healthy cartilage around the defect and microfractures, we proceed with closing the defect with Hyalofast. So that's a reminder for all of the surgeons. It's easy to keep in the operating theater, and in case that you don't have to re-operate a patient, maybe we should better have some with us in the operating theater. Thank you very much for your attention.
Cem, could you come here, please? I don't forget to invite you, please. Dr. Behrens, could you come here, please? Because you are one of the experts of microfracture, and your nano fracture is published in